Welcome to a new episode of NeoMed AI Podcast, the podcast that offers insightful AI for better neonatal care.
It's great to be here.
Today, we're tackling a condition that is arguably one of the most feared diagnoses on any neonatal unit, necrotizing enterocolitis, or NEC. It's a devastating disease that strikes the most vulnerable infants, and despite decades of research, it remains a significant challenge for us all.
It absolutely is. It represents the most common and severe acquired gastrointestinal emergency we see in neonates. The speed at which it can progress from subtle signs to a life-threatening catastrophe is what makes it so formidable. It carries a heavy burden of both mortality and significant long-term morbidity for the survivors.
So our goal today is to provide a really comprehensive, evidence-based overview, specifically grounded in contemporary UK practice. We want this to be useful for everyone, from the junior doctor just starting in neonates to the experienced consultant facing a difficult case. We'll structure our discussion around a representative case, starting with the fundamentals, then moving through the nuances of management, and finally tackling some of the most complex challenges and controversies.
An excellent plan. Let's dive in.
Okay, let's set the scene with a very typical and therefore very concerning clinical scenario. You're on call and the nursing staff contact you about a baby boy. He was born at 27 weeks and 4 days gestation with a birth weight of 950 grams. After an uncomplicated start, he is now on day 10 of life. The nurses are worried. They report that his abdomen has become visibly distended. He had a large bile-stained gastric residual before his last feed was due, and they found fresh blood in his stool. Systemically, he's become lethargic and his temperature is unstable.
That is the classic triad of signs that immediately makes any neonatologist think of NEC. The abdominal distension, the feeding intolerance demonstrated by the large aspirate, and the hematochezia, or blood in the stool, are textbook. The systemic signs, the lethargy and temperature instability, are equally concerning, as they suggest this is progressing beyond a localized gut issue into a systemic illness.
So, for the medical students or new trainees listening, let's be really clear. What is our working definition of necrotizing enterocolitis?
At its core, NEC is an acute inflammatory necrosis of the intestinal tract. Necrosis means the death of tissue. It's a disease spectrum. On one end, you might have what appears to be mild intestinal injury or severe feed intolerance. On the other, you have fulminant, widespread necrosis of the bowel, leading to perforation, overwhelming sepsis, and, sadly, often death.
So, you mentioned this baby was born at 27 weeks and weighed under a kilogram. How central is prematurity as a risk factor?
It is the single greatest and most consistent risk factor. There's a clear inverse relationship. The lower the gestational age and the lower the birth weight, the higher the incidence of NEC. The highest rates are seen in the very low birth weight infants under 1,500 grams and the extremely low birth weight infants under 1,000 grams, just like the baby in our case.
And just how common is it on UK units? Are we talking about something you might see once a year?
Oh, far more common than that. The most recent data from the UK's National Neonatal Audit Programme, reporting on 2022 figures, showed that 5.6% of all babies born at less than 32 weeks gestation developed NEC. That's more than 1 in every 20 babies in that high-risk cohort. It's a core part of neonatal practice.
Let's talk about the pathophysiology. What do we think is actually happening inside the gut to cause this devastating process?
It's incredibly complex and multifactorial, which is why we don't have a single magic bullet cure. The leading theory involves a sort of perfect storm. You have an immature intestine with a compromised barrier function. This gut is then colonized by microbes, but in a disorganized way, what we call dysbiosis. Then you introduce enteral feeding, which the gut isn't ready for. This combination triggers an exaggerated, out-of-control inflammatory response from the baby's immature immune system. This inflammation leads to ischemia, or a lack of blood flow to the bowel wall, and ultimately necrosis and tissue death.
You mentioned feeding. This baby was receiving expressed breast milk or EBM. We are constantly promoting human milk as being protective. What is the science behind that?
The science is fascinating. Human milk is so much more than just nutrition. It's a dynamic, bioactive fluid. It's packed with components that actively protect the gut. You have immunoglobulins, especially secretory IgA, which provides passive immunity on the gut surface. You have proteins like lactoferrin and lysozyme that have antimicrobial properties. And then you have human milk oligosaccharides, which are complex sugars that aren't for the baby's nutrition but act as prebiotics, promoting the growth of a healthy, beneficial gut microbiome. Together, these elements enhance the intestinal barrier, modulate the immune system, and fight off pathogens. It's a key reason why major UK bodies like the British Association of Perinatal Medicine, BAPM, have frameworks promoting maternal milk as a core strategy to reduce NEC rates.
The baby's blood gas showed a metabolic acidosis. Can you explain the significance of that finding?
A metabolic acidosis, often with a rising lactate level, is a very serious sign. It indicates that the body's tissues are not getting enough oxygen and are switching to anaerobic metabolism. In the context of NEC, this is caused by a combination of intestinal ischemia, the gut itself is being starved of oxygen, and the systemic effects of sepsis, which causes poor tissue perfusion throughout the body. It's a clear marker of severe illness.
And her platelet count had also dropped significantly. Why does that happen?
That's called thrombocytopenia, and it's another well-recognized and worrying finding. The overwhelming systemic inflammatory response and sepsis associated with NEC lead to the consumption of platelets. A rapid fall in the platelet count is considered a poor prognostic indicator, signaling a very sick infant.
Okay, so given this entire clinical picture, what is the single most important initial investigation that must be performed without delay?
An urgent anteroposterior, or AP, abdominal radiograph, an X-ray. It is absolutely mandatory. We're looking for the specific diagnostic signs of NEC. The most classic sign is called pneumatosis intestinalis, which is gas that has dissected into the bowel wall itself. You might also see gas in the portal vein of the liver. The most feared sign, however, is pneumoperitoneum. This is free air under the diaphragm, and it means the bowel has perforated. That finding changes the management from medical to surgical in an instant.
Before we move on to management, one of the hardest parts of this is speaking to the parents. How do you even begin to explain this terrifying diagnosis?
It's incredibly difficult and requires clarity and compassion. You have to be direct, but gentle. I might say something like, "Your son has developed a serious condition in his bowel that we call necrotizing enterocolitis, or NEC. This is an inflammation of the bowel wall that we see most often in babies born very prematurely. His tummy has become swollen, he is struggling to digest his milk, and we have seen some blood in his nappy. To manage this, we have stopped his milk feeds to rest his bowel completely, and have started him on strong antibiotics. We are monitoring him very closely with blood tests and X-rays to see how his bowel responds to this treatment."
Okay, let's progress the case. The abdominal X-ray is done. It shows dilated bowel loops and definite pneumatosis intestinalis. Crucially, there is no evidence of pneumoperitoneum. The blood results confirm the severity. His pH is 7.20 with a base excess of -10. His CRP is 80 and his platelet count has dropped to 60. This confirms Bell's stage 2 NEC. What are the immediate management priorities right now?
The moment that diagnosis is confirmed, a series of actions must happen simultaneously. The priorities are definitive bowel rest, aggressive systemic support, and broad-spectrum antibiotic therapy.
Let's break those down. What does bowel rest entail in practice?
It means making the infant nil by mouth, or NBM, immediately. All enteral feeds are stopped. We then pass a nasogastric or orogastric tube and leave it on free drainage or sometimes low-pressure suction. This is vital for gastric decompression to prevent further bowel distension from gas and fluid.
All of the baby's nutrition and fluids must now be provided intravenously, which means starting total parenteral nutrition.
And what about the systemic support for this very sick infant?
This is just as critical. The baby will need robust intravenous access to receive fluid resuscitation to correct the shock and metabolic acidosis. They will also need significant cardiorespiratory support. The abdominal distension itself can push up on the diaphragm, a phenomenon called splinting, which restricts lung movement and makes breathing difficult. This, combined with septic-induced apnea, often means the baby needs to be intubated and put on a mechanical ventilator. Furthermore, the sepsis can cause septic shock and hypotension, which frequently requires starting inotropic medications like dopamine or adrenaline to support their blood pressure and circulation.
You mentioned antibiotics. What is a typical empirical regimen used in the UK for confirmed NEC?
There is some variation between units, but a common approach, often guided by NICE guidelines on neonatal infection, is a combination of benzylpenicillin for gram-positive coverage and gentamicin for gram-negative coverage. For definite NEC with pneumatosis, most UK clinicians would also add metronidazole. This is crucial for covering anaerobic organisms, which are bacteria that thrive in low-oxygen environments and are known to translocate from a compromised gut. It's essential, however, to always follow your local unit and network microbiology guidelines.
Now, a question that always comes up, how long do we keep the baby nil by mouth?
This is a classic example of where practice is often based on consensus rather than high-quality evidence. The optimal duration is uncertain. For confirmed medical NEC, so Bell Stage 2, a period of 7 to 10 days of being MBM is common practice in many UK units. Some might go for 5 to 7 days if the recovery is swift, others 10 to 14. The absolute key is that you do not even consider reintroducing feeds until there is clear clinical and biochemical evidence that the inflammation has resolved. That means the abdomen is soft and non-tender, the baby is systemically well, and inflammatory markers like the CRP are returning to normal.
You mentioned Bell's staging. Could you quickly explain why this classification is so important?
The modified Bell's staging criteria are fundamental to how we manage NEC. It classifies the disease from stage 1, which is just suspected NEC, through stage 2, which is definite medical NEC, like our case, up to stage 3, which is advanced disease, usually meaning the bowel is perforated. Staging is crucial for several reasons. It guides our management decisions. Is this a medical case or a surgical one? It helps with prognostication, giving us an idea of the severity. And it provides a standardized language which is vital for clear communication between clinicians, during handovers, and for research purposes.
The initial X-ray was helpful, but is there a role for any other imaging?
Yes, a very important one. Abdominal ultrasound is an increasingly vital adjunct to the plain X-ray. While the X-ray is the best tool for spotting free air from a perforation, ultrasound can be more sensitive for detecting other key features. It can show us the thickness of the bowel wall, it can assess perfusion and blood flow to the gut using Doppler, and it can identify localized fluid collections or abscesses. It can be particularly helpful in that gray area where the baby is deteriorating, but the X-ray is unchanged, helping to guide that difficult decision of when to operate. Its use is definitely becoming more common in UK centres.
Let's talk about feeding again. This baby was on expressed breast milk. If, upon recovery, mum's supply is insufficient, what is the next best choice?
The evidence is very clear on this. When maternal milk is unavailable or insufficient, pasteurized donor breast milk is the recommended alternative over any preterm formula for high-risk infants. Multiple studies have shown that donor milk is also associated with a lower risk of NEC compared to formula. UK feeding guidelines and neonatal networks strongly advocate for this DBM-first approach.
That leads nicely to standardized feeding guidelines. I hear that term a lot. What are they and how do they help prevent NEC?
A standardized feeding guideline is a formal, written protocol that dictates exactly how enteral feeds are managed in a unit for preterm infants. It specifies the type of milk to use, when to start, and crucially, the rate of advancement. These protocols reduce practice variation and promote a cautious stepwise approach, typically increasing feed volumes by small increments like 15 to 30 milliliters per kilogram per day. The introduction of these guidelines has been shown in multiple studies to be associated with a lower incidence of NEC. It takes the guesswork out of it.
A controversial topic that always generates discussion is the link between blood transfusions and NEC. What's the current thinking on that?
This is a debated area often referred to as transfusion-associated NEC or TANEC. There is an observed association where some infants develop NEC in the 24 to 48 hours following a red blood cell transfusion. The exact mechanism isn't proven, but theories involve inflammatory mediators present in stored blood or temporary alterations in blood flow to the gut during or after the transfusion. While a definitive causal link hasn't been established and the evidence is rated as low, the association is strong enough that it promotes cautious transfusion practices and a heightened vigilance for any abdominal signs in the period immediately following a transfusion.
Looking at international practice, how does the UK approach compare to, say, the US? Let's start with probiotics.
It's a fascinating comparison. On probiotics, the situation is actually quite similar. Multiple meta-analyses, including a major 2023 Cochrane review, show that prophylactic probiotics do reduce the risk of severe NEC and mortality. However, in both the UK and the US, there are no licensed, pharmaceutical-grade, FDA or MHRA-approved probiotic products. They're classed as food supplements. This lack of regulation creates huge concerns about product quality, consistency, and safety, which is the primary barrier to universal adoption in both countries. So you see huge variation between institutions.
And what about other differences, like in surgery or antibiotics?
There are some subtle differences. For antibiotics, a UK regimen is often benzylpenicillin, gentamicin, and metronidazole. A common US approach might be ampicillin, gentamicin, and either metronidazole or clindamycin, with vancomycin considered if MRSA is a concern. Surgically, in both countries, a laparotomy is the standard for a perforation. However, primary peritoneal drainage, placing a drain in the abdomen as a temporizing measure without a full operation, has perhaps been more commonly used or debated in some US centers for extremely unstable infants, whereas it's used very rarely in the UK.
Okay, let's take our case to the most critical stage. Despite 48 hours of maximal medical support, the infant's condition deteriorates. He is now hypertensive, requiring significant inotrope support with dopamine and adrenaline. His abdomen has become tense and rigid, with visible redness or erythema of the overlying skin. A repeat X-ray shows what radiologists call a fixed loop, a segment of bowel that doesn't change position, but still no definitive pneumoperitoneum. An urgent ultrasound, however, shows markedly reduced perfusion in that segment and a complex fluid collection. The surgeons are now planning a laparotomy. This is the consultant-level challenge.
This is the tipping point. The clinical deterioration, the erythema of the abdominal wall, and the fixed loop are all relative indications for surgery. The ultrasound findings of poor perfusion and a collection seal the deal. You can't wait for free air on an X-ray in this situation. By then, the infant may be too unstable to survive an operation. This decision to operate without a clear perforation is one of the hardest calls in neonatology, relying heavily on experienced clinical judgment.
When the surgeons operate on this critically ill baby, what are their primary goals?
They have three main objectives. The first is control of sepsis. They must find and remove the source of the overwhelming infection, which means resecting all necrotic and perforated bowel. The second, and this is a balancing act, is the preservation of bowel length. They must resect only what is unequivocally non-viable to minimize the risk of the baby developing short bowel syndrome and lifelong intestinal failure. The third goal is to decide on the best surgical procedure. In a critically unwell, unstable infant like this, performing a primary anastomosis or rejoining the bowel is too risky. Bringing out a stoma, where the end of the bowel is brought to the skin, is almost always the safer and preferred option.
Let's discuss the absolute worst-case scenario. The surgeons open the abdomen and find pan-necrosis, meaning almost the entire intestine is necrotic. What are the management and ethical considerations in that moment?
That is a catastrophic finding with an extremely poor prognosis. From a management perspective, extensive resection would result in a bowel length that is completely incompatible with long-term survival off TPN. The surgical options are essentially to close the abdomen without resection or perform a minimal procedure knowing that mortality is almost certain. Ethically, this is the moment the entire focus of care must shift. It becomes about palliative and end-of-life care. This necessitates an urgent, honest, and deeply compassionate discussion with the parents, ideally involving the senior medical and surgical teams together. In line with Beaton's ethical frameworks, the goal is to redirect care towards comfort and dignity, as continuing aggressive and futile interventions is no longer in the baby's interests.
Moving to some other advanced topics, how should we be managing pain in an infant with surgical NEC?
This is crucial. NEC is considered a severely painful condition. Effective, preemptive analgesia is a core component of good management. For an infant with Bell's stage 2 or 3 disease, and certainly for any infant undergoing surgery, this requires a multimodal approach. This typically involves a continuous intravenous opioid infusion using morphine or diamorphine, combined with regular intravenous paracetamol. This powerful analgesia must, of course, be balanced against the risks of causing hypotension and respiratory depression, which necessitates very careful and continuous cardiorespiratory monitoring.
We've mentioned the risk of short bowel syndrome. For survivors of surgical NEC, what are the other major long-term morbidities we worry about?
The long-term outlook can be very challenging. Beyond the risk of short bowel syndrome leading to intestinal failure, poor growth, and TPN-associated liver disease, there is another major concern. Survivors of surgical NEC are at a significantly increased risk of adverse neurodevelopmental outcomes. This includes higher rates of cerebral palsy and cognitive impairment. Importantly, this risk appears to be independent of other prematurity-related risk factors, suggesting that the severe inflammatory insult of NEC itself has a direct or indirect impact on the developing brain.
And finally, what's on the horizon? Where are the major research gaps that need to be filled to improve outcomes in NEC?
There are several key areas. First, we need to solve the probiotic issue. That means large-scale trials to identify the optimal strains and doses to allow for the development and licensing of a pharmaceutical-grade, quality-assured product. Second is the search for biomarkers. Researchers are looking for a blood or stool test, like intestinal fatty acid binding protein, that could give us a much earlier and more specific diagnosis. Third, we need more objective indicators to guide the timing of surgery to reduce the reliance on clinical judgment alone. And finally, a huge area is neuroprotection. We need to find strategies to mitigate the high risk of poor brain outcomes for these survivors.
This has been an incredibly comprehensive and valuable discussion. To wrap everything up, if you could leave our listeners with 2 or 3 key take-home messages from our deep dive today, what would they be?
I think the first is to maintain a relentless, high index of suspicion for NEC in any preterm infant who is not quite right, especially if there are any abdominal signs. Trust your clinical judgment and your nursing team's instincts. Second, champion the use of human milk, both maternal and donor, as it remains one of our single most powerful and evidence-based preventative strategies. And third, communicate. Communicate early and clearly with your surgical colleagues, communicate constantly with your team on the unit, and most importantly, communicate compassionately and repeatedly with the family who are going through a terrifying experience.
An excellent summary. And a final thought for our audience to ponder as they go about their clinical work. Considering the push towards prevention with initiatives like NEC Zero, what is the one small, evidence-based practice change that you could champion in your own unit tomorrow to help protect your patients from this devastating disease?
A very important question for us all to reflect on. Thank you for the conversation.
And thank you all for listening to the NeoMed AI podcast. Just a reminder, this AI-generated information is for educational purposes only and is intended for trained neonatal clinicians. It does not replace independent clinical judgment. Always refer to the current national and local guidelines.